Today's episode is all about the processes that power the patient experience. Too often the patient experience is thought to be created by aesthetic finishes and spa-like lounges and amenities, but we want to go beyond all of that and discuss the processes that truly create patient experience. We're joined today by Amy Anderson, a seasoned plastic surgery practice management consultant and founder of ACG Practice Partners. And we'll be discussing what truly shapes patient satisfaction, which is, of course, the operational systems behind the scenes. From the operating room to post-op protocols, we'll explore how seamless internal systems can elevate the patient journey and the practice's bottom line. Amy, thank you so much for joining today.
Thank you for having me.
Very much looking forward to this conversation. If you don't mind, we'll just jump straight into some thoughts, some questions here for you. Want to draw on all of your experience and help offer some insightful education to our audience. The first question I would love to cover is just, how, in your opinion, is it fair to say that the OR, the operating, the OR suite, is often one of the most overlooked parts of the patient experience in aesthetic practices?
Oh, wow, Bruce, that's such a great question because I would say for sure, yes, it is one of the most overlooked. We spend a ton of time working with all kinds of practices and particularly with aesthetic practices on the patient experience from, the first phone call, the first contact with the office. We focus heavily on what it's like when they come in for consultation and that whole flow through the practice. I do think most practices do very much have that top of mind and are thinking critically about that. But then the day of surgery, we tend to get very hyper focused on important things, the clinical process. I by no means want to take away from that. But sometimes we forget that this is, an incredibly scary day for a patient.
Yes.
And we have tremendous opportunity to smooth that out, bring down their stress level, cater to their family members or their caregivers who are coming with them to surgery. So I do think while it is critically important that we are thinking about the clinical aspects and the safety and the quality, that we don't forget that the experience on the day of surgery can have such a huge impact on their overall experience with the practice.
Yeah, could not agree more. I guess from your experience in coming into practices and auditing practices, what are some of the most common gaps that you see in the OR operations? Some of those things that you see on surgery day, just some of the most common gaps that you would typically see.
Yeah. Well, I think it actually starts before surgery day. So even thinking about what that preoperative phone call is like, sometimes depending on the practice setting, it's a clinical person on the office side. Sometimes it's on the OR side. Sometimes that's the same person that works with the surgeon in both ends of the practice. But contacting the patient ahead of time, not just to go through the checklist of items that are very important, but to just make sure they know where they're coming, they know what time to arrive, they're feeling comfortable, that they have really good understanding of what to expect. I think you cannot say too many times what the flow of the day will be like. So on that first call to say, you're going to arrive at 6:30 a.m. and Judy's going to be there to open the door for you. She's going to take you back, get changed into a gown, right? And go through what to expect. People very much like to visualize that because walking into an OR is not something they do every day. And then the same thing when they arrive that day, repeating again, this is what we're going to do this morning. This is how it's going to flow. Who's going to come see you next? I think that is really important, both for making sure we don't miss a step and just to put them at ease. But in terms of other gaps, I think there's the details within the details of intake and discharge. One particular story that comes to mind that I'd love to share is about like the whole discharge process. And every OR has protocols about who can we discharge a patient to, what that handoff looks like. For example, everybody pretty much knows like you can't put them in a rideshare service by themselves. They're post anesthesia. they need a responsible adult to go with them and stay with them for 24 hours. But how do we prove that it's a responsible adult? And so we were chatting before this, Bruce, and I shared with you a story about a practice where it was a mother that was having a facial plastic surgery procedure, and her daughter was her chaperone and going to take her home. And the daughter was very responsible. She was very engaged, very helpful. She was there for all the discharge instructions. And they're walking out the door, and the nurse looked out in the parking lot and saw the vehicle she was driving and commented on it. She goes, "Oh, that's a really cool car you have." And she said, "Thanks. It was my 17th birthday gift." And alluded to like that was a few months ago. And we're like, okay. And then wait a second. After they leave, like, wait, but when did she turn 17? Wasn't her
That's right.
18th
Yeah.
birthday. And so it came to the realization that this patient was just discharged to a minor, and everything was fine. Like I'm happy to say there were no side effects or anything that went wrong, but that could have been a very bad thing. And so when we talk about protocols, it's not just, yes, we have to discharge to a responsible adult. And how do you do that? Do we need to look at an ID? Do we need to just at least confirm their age? That's just one example of the level of detail that really is essential in the whole process.
Yeah, that's such a good illustration or story to illustrate the point of how safety risk immediately becomes what's at the forefront when there is just perhaps protocols that are not there to follow. No ill intent. Glad to hear that story didn't end in a bad place, but there was certainly safety risk there if for some reason something went awry.
Mm-hmm.
So that's a really really good illustration. I also love your point just before around the giving the patients good insights ahead of the surgery day, what to expect from literally when they arrive through procedure, through discharge, and kind of paint that picture. Having only just recently had my 3-year-old son went through a very, very minor procedure, but had to be, under anesthesia. So it's stressful as a parent, what's the process going to be like. And the practice did a really, really good job of explaining, it's going to be at a different site. It was at an outpatient surgery facility, but what to expect on arrival and what to expect through the process and through recovery and then discharge. And it just, they even had like a cheat sheet, if you will, kind of a step-by-step what to expect. And then, things to bring just for, the comfort for the patient, and just went, in my opinion, above and beyond. But I think that could be the normal. That should be the normal, really, to create that patient experience, to really make it one that is far takes out the scaries of the experience. But no, that's really really good to consider the safety risk. I guess it points out how important the process documentation is. It's not just for the sake of having process. It's truly to it's truly to de-risk a situation. But maybe you could share with us on some of those protocols, for example, sterilization protocol. How detailed should these processes and protocols be? Just talk us through that, maybe.
Yeah. They need to be detailed. I often have a conversation with a surgeon that has their own in-office surgery suite, and we have to really consider first and foremost on the staffing side, who's been hired to work in the OR, and every state's going to have some different criteria as far as if a certification's needed to be a scrub tech, or if it needs to be an RN who's circulating or not. But aside from the credentials, just because somebody is an RN doesn't necessarily mean they've worked in an OR or understand the details of OR workflows, or just because somebody is a certified surgical assistant or surgical technician. If they've only worked in a hospital, they may not ever have sterilized instruments, because the hospital has a whole department that's all they do. And so you have your techs that do sterilization, you have your techs that work in the OR. In an office setting, kind of everybody has to do everything. And so it's a first, like, starting with, don't assume that just because they've done this job or they've done it in another setting that they know the whole process. And then obvious things, your sterilizer is probably a different model than a sterilizer in a hospital or even in another outpatient surgical environment. And it has to be detailed. There has to be appropriate training. I'm really in favor of just, simple steps, 1, 2, 3, this is what to do, and photos where that's helpful. But I actually was just having a conversation yesterday with a plastic surgeon who was pretty upset. She had a patient recently develop an unusual type of infection several weeks post surgery, and it was facial surgery. So they'd done some facial fat grafting, and she just developed these kind of strange nodules under the skin that almost looked like abscess. And they cultured it, and they just gotten the results back like before my meeting with her. And it's a very kind of rare, unusual microbiome of some sort that's going to be very difficult to treat. And of course, their first inclination is, oh my gosh, is this our fault? Is this our equipment? And right now, we actually don't know the answer to that. They've also cultured, they retested all of their equipment when they knew that she had this infection had developed. So they rechecked all their sterilization. They ran the controls. They're actually running cultures on the devices, and they're not doing any more of these procedures right now until they have some answers. But I can tell you she's losing sleep at night. And we have a patient who she's okay. She's going to be okay, or we think, but she's got a long treatment ahead of her now. And particularly when you can come in for cosmetic surgery, and now you're dealing with this infection that requiring an infectious disease specialist to manage. I mean, this is obviously what nobody's goal. Nobody wants this to have happen. And so we'll go through everything again with a fine-tooth comb to see, was there a breakdown in the process? Did it just happen, or did she contract this, elsewhere? So, but it just further emphasizes the reason why this has to be spelled out, and your team members have to be appropriately trained. Because at the end of the day, it's the surgeon's license on the line, and the surgeon is the one who has to manage the patient through this. The surgeon's the one who bears the liability if something happens. So, but one of the, on just a little bit of a lighter note, when it comes to documenting the processes, and I mentioned before using photos, and even just from an operational standpoint, when it comes to setting up the OR, every case has a different setup, and every surgeon tends to have different preferences of what supplies, what instruments they like to use. Anybody who works in the OR has heard of preference cards. But I really love when we get into it, to set up a full tray or a full sterile field for a case, and then just take a photo of it and then put that in with the process. This is how you set up for a blepharoplasty. This is how you set up for an abdominoplasty. And here's a photo of what it looks like when it's done. And so when you have new team members come in, they have the step-by-step written guide, and then they have the photo to compare it to. I mean, let's just break it down and make it, I don't want to be offensive and say dummy proof, but let's make it dummy proof that anybody could, that Bruce, you or I could walk in and probably be able to figure it out, even though, we're not the clinical team.
Yeah, no, that's so good. That's, I guess it just, that as you're going through that scenario with that patient, there's so much of processes and protocol that's, of course, intended to prevent something like that from happening. But then there's also the other side of it that, things happen. Perhaps it wasn't, like you say, it might not have even been as a direct result of the cosmetic procedure that was done, but a practice in a surgeon to be able to point to protocol if and when something like that does happen, to point to protocol that was followed. There's certainly a liability mitigation standpoint to all of this as well. So it's first and foremost prevention, but then also liability mitigation. So just points out how critical it is. You'd mentioned something just now about new staff coming in. Also wanted to touch on per diem staff, what the approach is to onboarding per diem staff to ensure that they uphold the OR standards, that that you can bring in new staff or per diem, and that a surgeon in a practice group can know with certainty that OR standards are upheld? What are some considerations around that?
Yeah, this is super common in an OR setting, right? We tend to have our core team members, and then we have to have a pool of backup so that we don't have to cancel a case because we were short on staff. And so having some per diem people come in, I do strongly believe that they still need an onboarding process. I mean, without a doubt, they have to be credentialed. That's going to be required by your accreditation entity, whether it's quad A or triple A or joint commission. But so in addition to just getting their credentials, they should be oriented to the OR. They should, know what's where, and just any specifics that they're going to be doing. I would highly discourage you from having multiple per diems on one day. And I'm saying per diem, I mean like truly like the float person, the fill in, the temp kind of employee personnel, because somebody needs to be there that is watching the whole process, and that is really kind of your quality control. At the end of the day, I mean, surgeons, when this is your own OR, it needs to be you that is ensuring that it's all being handled. Ultimately, I don't know that it all can be delegated, but it's great if you have a nurse or a tech on your team who has been with you for a long time, and you trust and you know that they're watching out for it. But so I think, when that per diem comes in, making sure there's like a buddy system, that somebody is overseeing what they're doing, just making sure any of the critical steps are not missed. If we have those protocols in place, the written checklist, the things, it's just referring to the checklist. Did it get done? Making sure they know to follow it. And yeah, and then staying in communication, making it has to be a safe environment to ask questions. I think the worst thing that can happen from either a surgeon doing this or another team member is like getting annoyed with the new person who doesn't know, or just, well, you work in the hospital, you should know this. Let's give everybody grace, and you have to make it a very safe place to ask questions, because not asking questions is a lot scarier
Yeah.
and has a lot more risk and potential for something to go wrong.
Yeah, that's good. No, I think that covers it very well. It's not only the pre-orientation ahead of surgery day. There's got to be some orientation, but also just having the resources, when in the OR, that they're not just expected to know everything, that they have the resources to draw on. So that's really helpful. Maybe just a few signs you could share with us, a few signs that maybe a team isn't truly, let's call it, OR ready. Even if everyone has, like you mentioned before, everyone has the right credentials on paper, but coming into, again, in maybe more of like an audit sort of environment where you're analyzing things, what are you looking for? What are some signs that just stand out that a team isn't ready?
Yeah, I think I'm always looking at communication and how well the team, and that's from the surgeon to the nurse to the tech to the anesthesia provider, that everybody is able to openly communicate. Like I said, that it's a safe place to ask questions, to talk about things. I would say if the surgeon has completely delegated every bit of it to somebody else, I would say they're not OR ready. They need to understand how everything works in their own facility, and they need, again, to take that ownership of it. I think, I'm always kind of gauging. It's okay to be a little bit nervous if this is like your first day, you're finally opening the OR. I think there's always a little bit of nerves and both excitement and anxiety about it. But there should be a confidence that everyone knows what their job is and what the expectation is. And if there's any question, we need to pause and we need to figure it out. I highly recommend that before a case happens in a new facility, that we walk through that flow, and maybe multiple times, but okay, literally have somebody walk in the front door, and who's greeting them, and where do they go, and what happens next, and then what's the handoff, and all along the way, what's the paperwork that's being done. But really walk through a full encounter. Obviously, we don't need to like prep the patient and put them on the table. I mean, maybe you do if your team hasn't done that before, but at least those core parts of moving a patient through that day of surgery experience, I think, is essential, that everyone knows their role before we bring a real patient through it.
It's really good. It's like a heat check. That's fantastic.
Yeah.
The communication, I could not agree more. It might sort of it might overlap with the other question that I had in mind here regarding sort of the patient and what they notice, even
Mm,
subconsciously, that can erode trust if operations aren't tight behind the scenes.
yeah.
We've talked about a lot here around risk and uh, risk mitigation, and then the patient experience. But just back to the patient specifically, what are they likely to notice that would erode that trust? Because of course, as we talk about patient experience, it's what we're trying to protect from, is make sure the patient just feels confident in the team every step of the way, every step of the journey. So what might it be that they would notice that we should be aware of?
I always say that if there is underlying drama or issues or tension among the team, you might think you're hiding it, but patients always pick up on it. Like you said, it could even be subconsciously, but there is an overall feeling of unrest. And that is the last thing you want in your OR. It's the last thing you want in your practice, but especially in the OR setting. And so if there's any beef with someone, if there's any tension, like you just have to figure that has to be worked out, because we can't accept that. Like it's bad anyway to let something like that fester in your practice and build. Almost all issues can be resolved fairly quickly with a conversation, and just getting things out in the air and working through it. But I would say that's the number one thing that the patients are going to feel. And then it's going to make them wonder, well, do I want this person in the OR with me? Is my surgeon going to be distracted? Or just things like that. So I think making sure that it is open communication, we're dealing with things as they come up. So there is nothing, under the surface that a patient can sense throughout their day of surgery.
Love that. That's so good. Has to be that strong working relationship. That's for certain.
Mhm.
Well, I wanted to maybe just wrap up with some quick wins for our audience. What are some maybe first steps or quick wins that a practice can take to audit and then elevate their OR flow and how they handle their OR suite? What are a couple of things that come to mind?
Yeah. Well, if you already have an OR, I really just challenge you to do the exercise of walking through it step by step. A lot of times, especially when you've been in it for years, everything becomes routine, and that's great. We like routine. Routine is good. But routine can get a little stale. Or the other thing that happens is details that we started with in the beginning tend to get watered down over time, and sometimes the surgeon doesn't even realize, and they'll say, wait, when did we stop doing this one thing? And you're like, I don't know, I was never trained to do that. And so I think it's always good to take a step back and say, let's walk through it, let's put on fresh eyes and see, if this is me as the patient, how would I feel about it? Sometimes you have somebody come through that's a family member or a close friend, and they're willing to give you that objective feedback, which I think is also incredibly valuable. We need to be open to that. I recently worked through this with a practice that we're really focused right now on all of the preoperative and postoperative instructions, and like literally like the paperwork and the communication that is sent to the patient prior to surgery and what they go home with as part of their discharge instructions. And we looked at it, and like it was all good information, but we started with a one-page thing, and then at some point somebody added another document, and then somebody added something else, and so we had all of this mismatch of information, and it was overwhelming to patients. And so to kind of put it all out on the table, consolidate it, redesign it, make sure it makes sense from a flow standpoint, and we're almost over the finish line with it. But we have this really beautiful surgical packet now that is going to take them step by step. You mentioned with your son, you even have a list of like suggested things that you want to bring to surgery. We have a suggested shopping list that will make recovery a little more comfortable. They're not must haves, but they're really nice to have things. And so, first, of course, covering those core pre and post op instructions that are non negotiable, but then adding in those layers of you might consider this, or this could be a nice touch. So I would just really encourage everybody to put fresh eyes on and walk through every step. This is more than a 1 hour project. It usually takes a couple times and a couple meetings and working through it. But just identify those things that you can elevate, and then make the changes. Those little changes really go a long way.
think that's so good. The fresh eyes coming into the facility, like you say, if it's someone that is willing to give you the their true perspective, I think that can be so just uncover things that otherwise might be overlooked because you walk past it every day. So I think that's can be so powerful. Well, Amy, thank you so much for pulling back the curtain on what really drives an exceptional patient experience. If you're a plastic surgeon building or refining your practice, this conversation is a powerful reminder that great outcomes start with great processes. Be sure to connect with Amy at ACG Practice Partners and follow Apex Design Build for more insight into what makes healthcare spaces and systems work better. Thank you so much.